Hello, my name is Brian Edlow, and I'll be presenting on imaging in disorders of consciousness. Some of the work that we'll be discussing was funded by a variety of federal, foundation, and departmental sources, and I have no financial disclosures or conflicts of interest to report. The goals for this talk are as follows. First, we'll discuss the clinical motivation for the development of advanced imaging techniques that aim to map the connectivity of brain networks that support recovery of consciousness after brain injury. Second, we'll talk about the state of the science in this field. Third, we'll talk about some clinical applications of these techniques. And then finally, we'll talk about how advanced imaging tools can be used to guide selection of targeted therapies for individual patients. First, the motivation for this work. Our aim is to use these tools to improve acute care and long-term outcomes for patients with severe brain injuries. Now, I put an asterisk here because just as COVID-19 has affected every other aspect of our lives over the past year and a half, we and many other labs around the world are also applying these techniques to patients with disorders of consciousness after COVID-19, and I'll be showing some of those data to you later. We also aim to support families and surrogate decision makers who face a fork in the road life or death decision, typically within the first 7 to 10 days of their loved one's admission to an ICU. Do they continue with life-sustaining therapy, which typically involves placement of a tracheostomy and a feeding tube? Or if even the best case scenario for long-term recovery is a quality of life that would be unacceptable to that patient, then do we change the goals of care to comfort-focused care and allow that patient to pass away peacefully in the ICU? The challenge that we face is that our diagnostic tools often fail to detect preserved brain networks that could support long-term recovery. Similarly, our prognostic tools fail to reliably predict outcomes. And so I begin and end every family meeting with a message of humility and an acknowledgement that prognostication in the ICU is an uncertain art and science. There are other ICU clinicians who I think can reasonably be said to have a more pessimistic approach to prognostication. This prognostic pessimism is evidenced by the largest study to date looking at causes of death in the ICU in patients with severe TBI. This is a study of over 600 patients at level 1 trauma centers in Canada that found that 70% of all TBI deaths in the ICU were attributable to withdrawal of life-sustaining therapy. So were all of these patients destined to have a poor outcome anyway? Well, only about half of them had an unreactive pupil. Only about a quarter had evidence of herniation on CT, two of the findings we typically associate with a devastating prognosis. And what emerges when you read the discussion of this paper is that it is the manner in which we, the clinicians, are communicating with families that is a primary determinant of family decisions to withdraw life-sustaining therapy. So let's be clear about the stakes of an incorrect prognosis. If we are overly pessimistic, then a patient who had the potential for recovery may have life-sustaining therapy withdrawn and pass away in the ICU. On the other hand, if we're overly optimistic, then a patient could end up in a vegetative or minimally conscious state that he or she would never have found acceptable. So for the next 15 minutes, we're going to be talking about the state of the science in this field of brain mapping. How can these tools, these advanced imaging tools, be used to improve diagnosis, such as by detecting covert consciousness with functional MRI? How can they be used to improve the accuracy of our prognosis, such as by mapping the structural and functional connectivity of brain networks? And then how can we also use them moving forward to select patients for targeted therapies? First, diagnosis. Many of us are familiar with the Glasgow Coma Scale score, or GCS. This was designed to be performed rapidly within 30 to 60 seconds to allow us to make key triage decisions like, does this patient need intracranial pressure monitoring? Does this patient need to go to the operating room for evacuation of a mass lesion or an extraaxial lesion? These are the types of roles that the GCS can play in facilitating clinical care. When it comes to the assessment of consciousness, however, there are more comprehensive assessments that can be performed that enhance our ability to detect consciousness. The Coma Recovery Scale Revised, for example, or the CRSR, is the gold standard behavioral assessment in inpatient rehabilitation settings during the subacute and chronic stages of care, but it's often not possible to perform this acutely in the ICU. Many of our patients are not able to tolerate being off of sedation for the 30 to 45 minutes that it can sometimes take to perform the CRSR assessment. But if our patients are able to tolerate being off of sedation for that long safely, then the CRSR has been shown to increase the detection of consciousness by upwards of 40% over standard assessments like the GCS. And this is because of additional diagnostic techniques like the use of a mirror to assess for gaze tracking. Let's imagine now for a moment that we could also perform task-based functional MRI for all of our patients in the ICU. The idea here is that we place earphones in the ears and we ask a patient to imagine performing a motor imagery task, like imagine opening and closing your hand. Multiple studies by our group and others have now shown that even patients who appear unresponsive on the CRSR, about 15 to 20% of them will show evidence of command following with fMRI, that they can volitionally modulate their brain activity during the fMRI scan. So what do we call these patients? What is their diagnosis? One term that's been proposed is covert consciousness. Another is cognitive motor dissociation, the idea being that there's a dissociation between a patient's level of cognition and his or her level of motoric expression. And so what I'd like to do now is to give you a feel for some representative data that we acquired during a pilot study at Mass General Hospital in Boston, Massachusetts, between 2012 and 2014. These data included both functional MRI and EEG assessments, but for the purpose of this talk, let's focus on the fMRI data. In this column, we're looking at the motor imagery data, imagine opening and closing your right hand. And then we also played for these patients language and music to see what their brain responses would be. The top row is a healthy control subject. And what we see in response to language and music is an activation within the superior temporal gyri bilaterally. And to the motor imagery task, we see activation within the supplementary motor area and the premotor cortices bilaterally, right out of the textbook. The next patient's a middle-aged man who had just recovered the ability to follow basic commands at the bedside. He could open and close his hand to command. And when we performed the fMRI, he responded to language and music. And although his area of response to the motor imagery task was less robust, he also responded within the SMA and the premotor cortex. His fMRI data were therefore consistent with his bedside behavioral assessment. We didn't learn anything new from the fMRI. The third row, however, is a young woman who was in a vegetative state based on her behavioral exam. She was an unhelmeted motorcyclist who crashed into a wall. Yet here are her fMRI results. She responds to language within her superior temporal gyrus. This is in radiologic convention, so this is the left side. She responds bilaterally within the superior temporal gyri to music. And here is her response within the premotor cortex to the task-based fMRI assessment. Evidence of covert consciousness. She goes on after a lengthy inpatient and outpatient rehabilitation to have an excellent recovery and becomes fully functionally independent. The next row is a young man who was a pedestrian hit by a car. He was scanned just 25 hours into his injury. And at the time of his fMRI, the behavioral assessment suggested no evidence of language comprehension or expression. The only signs of minimally conscious state were that he would localize to a noxious stimulus. Yet he responds with fMRI to language and to music. He does not respond to motor imagery, so he does not meet criteria for covert consciousness, but I would argue that we have still learned something new here. We have seen that in this young man who does not have evidence of language processing on his behavioral exam, that his superior temporal gyri can respond to a language or a music stimulus. Now, this passive response does not prove that he's conscious, but it shows that the neurons in those association cortices may be able to process stimuli appropriately and may thereby provide a structural and functional architecture for subsequent recovery. He too goes on to have an excellent recovery after a lengthy inpatient and outpatient rehabilitation and becomes fully functionally independent. The last patient is a young woman who was an unseatbelted passenger in an SUV accident. Her behavioral assessment suggested a coma at the time of her scan, and she shows no response whatsoever to language, music, or motor imagery. She also goes on to have an excellent recovery after a long inpatient and outpatient rehabilitation. She graduates from college, rejoins the workforce, fully functionally independent. And I always finish with this case to highlight the point that this test, like any other diagnostic or prognostic test that we use in the ICU, has fundamental limitations. The most important of which, in my opinion, is a high false negative rate. So for the motor imagery task, if all of us on this Zoom right now were to undergo this same assessment, 25% of us would have a negative result, either because we're not paying attention, or we're not trying to do the task hard enough, or we're falling asleep. In this young woman's case, she was on a propofol drip at the time of the scan. That may have confounded her results. And so the reason I focus on this limitation is that if we are going to share these results with families, and I'll mention here that our institutional review board, our ethics board, does allow us to share the results with families at their request. Of the 75 or so patients we've studied since 2012, every single family, 100%, has asked to get access to these data. And when we share the data, we explain that a negative result, absence of activation, does not prove that that patient is going to have a poor outcome. So why does this matter? Why do we need to get the diagnosis right for long-term prognostication? Well, let's look now at some of the advanced imaging techniques that are being developed to improve the accuracy of our prognostication in the ICU. One technique is called diffusion tensor imaging, a structural connectivity technique where we're looking at the connectivity within neural networks based on the directional diffusion of water molecules along axonal tracks. This study, led by Sam Snyder, who's now a member of the Neuro-IC faculty at Brigham and Women's Hospital, looked at the same cohort of 16 patients that we studied with fMRI on the prior slide. And here we asked the question, can we detect disruptions in the subcortical arousal network that links the brainstem tegmentum to the thalamus, hypothalamus, and basal forebrain? Can we detect coma-causing disconnections in this network in patients as compared to controls? And what we found in this study is that when we looked at this subcortical arousal network, there were fewer connections in the patients as compared to the controls, as shown here from a sagittal and an axial point of view. And here are the peak areas of network disruption, shown here in orange, and those that survive correction for multiple comparisons are shown in white. Now, we can't prove that these disconnections cause these patients' comas, but there was an association between patients who arrived at the hospital in a coma and disruptions in this particular network. And exactly which pathways most specifically correlate with the pathogenesis of coma is something that's an area of active study. In this next video, this is from the same data set, we're going to be looking at sequential axial sections from the mid-pons up through the thalamus. And in red, we're going to be looking at normal areas of connectivity in healthy controls. In white are the areas of disconnections in the patients with traumatic coma. We see these in the dorsolateral quadrant of the midbrain, in the midline raphe, and we also see these disconnections tracking up into the central thalamus, consistent with prior histopathologic studies in this population. So we are now able to see on data that were acquired on a clinical 3 Tesla MRI scanner with a diffusion sequence that takes 9 minutes to acquire, we are able to see disconnections in the subcortical arousal network that may be responsible for causing coma in this patient population. And again, we're now trying to test whether these disconnections predict who is going to recover in the long term. Let's transition now to resting state functional MRI, another technique that's getting a lot of attention in this population. One of the earliest studies looking at resting state fMRI was published by Audrey van Houdenhuis and colleagues. This is in Stephen Laurie's lab in Liège, Belgium, where they looked at the default mode network, a network that appears to be responsible or at least contribute to conscious awareness. And they found that the connectivity between a key hub node of this network in the posterior cingulus and precuneus, the connectivity from that node to the rest of the network appeared to distinguish those patients in a minimally conscious state from those who are in a vegetative or comatose state. We subsequently replicated these findings in a population in the ICU with severe traumatic brain injury. This was a study led by Zach Threlkeld and Elena Bodine. Dr. Threlkeld's at Stanford, Dr. Bodine is at Mass General. And we again found that the posterior cingulate, its connectivity, as well as the connectivity of the medial prefrontal cortex, appears to distinguish between those patients who are in a minimally conscious state or a confusional state with those who are in a comatose or vegetative state. It's important to point out, however, that connectivity within the default mode network appears to be necessary for recovery of consciousness, but it is not sufficient. One of the first studies to show this was published in 2012 by Norton and colleagues. This was a small cohort of patients with cardiac arrest, where the authors observed that all of the patients who were comatose and went on to recover consciousness, they all had a partially preserved default mode network while they were comatose. But some patients who had a partially preserved default mode network never went on to recover consciousness. And multiple subsequent studies, including this very elegant study by Athena Demerzi and colleagues, showed that there are multiple resting state networks whose connectivity reemerges as patients recover consciousness. And just like we mentioned for the structural analyses, trying to understand which functional networks, which combinations of these networks are essential for recovery of consciousness is a key area of ongoing work in this field. There are multiple studies now showing that early resting state connectivity in the ICU predicts long-term recovery. Now, it's important to point out that sample sizes are limited. In these representative studies of resting state fMRI, the sample sizes range from about 13 to 112. So we are nowhere near where our cardiology or oncology colleagues are with hundreds or thousands of patients in their studies. But we are now beginning to see in both the cardiac arrest and the TBI population that there may be some prognostic utility to these types of results. And what I'd like to share with you now is an early clinical application of this technique, resting state fMRI, to map the default mode network's connectivity. It's important to point out here that there are critical ethical considerations for us to discuss as a community about the appropriateness of clinical implementation, about when and where and for which patients it is appropriate to, and how we can ethically, responsibly implement these techniques. But what I'd like to share with you now is one example of how we did so at Mass General. This was in the early stages of the COVID-19 pandemic. We were actually in the process of writing an IRB research protocol to do this, but the protocol had not yet been approved. And so with the permission of the clinical team and this patient's family, we performed resting state fMRI as part of a clinical assessment to inform his prognosis. So let's take a look at his data. This was a 47-year-old man who survived severe COVID-19, but remained unresponsive after about a month of mechanical ventilation. We're looking at time on the x-axis. These blue dots represent the patient's PaO2 values on an arterial blood gas. And we see that they intermittently fell below our target of around 60 that we use based on the ARDSNet guidelines, but he never had a hypoxic arrest. When we look at his mean arterial pressure data, shown here with the red line, we see that they intermittently fell below 65, our target for the sepsis guidelines, but he never had a cardiac arrest. We see that he was mechanically ventilated for 32 days on a variety of paralytics and sedatives. But when the sedatives were turned off after about a month, he continued to be in a vegetative or minimally conscious or even comatose state, fluctuating between those states. And the question was, why was this patient not recovering? Why was he not waking up? So here is conventional MRI data. We see hyperintensities in the putamina bilaterally, in the caudate heads, and in the thalami. There's some subtle diffusion restriction there as well. On EEG, we see a disorganized background with delta slowing, all of which suggests a relatively poor prognosis. But here are his resting state fMRI results. We performed this analysis by looking at key nodes of the default mode network, the posterior cingulate region, the medial prefrontal cortex, and the inferior parietal lobules. Here's a representative healthy control scanned on our 3 Tesla scanner in the Neurosciences ICU at Mass General Hospital, just to give you a feel for what a normal default mode network connectivity looks like. Here's a different patient with a disrupted default mode network, just to reassure you that we don't detect this network in every patient that we study. And here is our patient. I would argue that his default mode network appears to be qualitatively and quantitatively indistinguishable from those of controls. And this was an analysis led by Dr. David Fisher, who is a neuro-ICU fellow at Mass General Hospital. Dr. Fisher, myself, and others met with the primary clinical team and with this patient's wife. She happened to be an ICU clinician, and discussed this result within the context of the broader landscape of prognostic data. This was one piece of a very large prognostic puzzle, and the patient's family decided to continue with life-sustaining therapy. 20 days later, he begins to follow commands reliably, begins to mouth words, and here he is a year later. This was a video taken with the patient's consent. This was really recently published in the journal Neurocritical Care, showing him at home with his wife. This was a video taken during a teleneurology visit that Dr. Fisher and I performed. And you can see that he's able to sit up in bed. He's smiling. He's able to lift his arms. Here's the happy birthday balloon. It was recently his birthday behind him. He was still quite weak in his lower extremities. He had lingering effects of ICU myoneuropathy. So he had ongoing physical disabilities, but he had essentially imperceptible cognitive disability. His wife mentioned that his cognitive processing speed was a little bit slower than pre-injury, but otherwise he tested normally in a routine neurologic examination. And he stated to us just subjectively that he was happy to be alive and happy to be home with his family. So here's a situation where the resting state fMRI certainly wasn't the only piece of prognostic information that was considered by the family and the clinical team, but it perhaps helped us to provide the family with a more complete picture of this patient's chances of recovery. So how can these techniques be used to guide therapies moving forward? There are several studies that are now being performed around the world that are using this type of approach where imaging can guide the therapeutic targeting of specific network nodes. We recently launched a study in the MGH Neuro ICU where we're using intravenous methylphenidate, and we're testing the hypothesis that patients who have partially preserved connectivity from the dopaminergic ventral tegmental area to rostral sites in the thalamus, hypothalamus, basal forebrain, and cortex, these are the patients whom we expect will be responders to methylphenidate, because you need to have some axons intact releasing dopamine at the synapse for this dopamine reuptake inhibitor to be efficacious. There's also a low-intensity focused ultrasound pulsation study that's being led by Martin Monti, Caroline Schnakers, Paul Vespa, and colleagues at UCLA. Moving forward, one of the hypotheses that will be tested here is that patients with partially preserved thalamocortical connectivity are likely to respond to this non-invasive central thalamus stimulation. We call this the connectome-based clinical trial platform. And here's an example of a patient with severe TBI who we'd expect would respond to methylphenidate. We're looking from a lateral perspective at a patient with severe TBI as compared to a control, and we're looking at tracks measured with diffusion tensor imaging that connect from the ventral tegmental area to other areas of the brain. What we see in the patient is that there are far fewer tracks as compared to the control. But we also see that some tracks are preserved, including those connecting with the medial prefrontal cortex. And so this is the type of patient whom we hypothesize will respond to methylphenidate. This is our imaging moonshot, our 100 micron MRI that was acquired over 100 hours of data acquisition in a post-mortem ex vivo human brain specimen. Even our most dedicated control subject cannot lie still for this long. So why am I showing this video? Why are we looking at ex vivo data that were acquired at 100 micron MRI, a spatial resolution that simply cannot be achieved in vivo with today's technology? And I should mention that this was work that was performed in collaboration with Bruce Fischel, Andre Vanderkow, and a large team of collaborators at the Martino Center at Mass General Hospital. The reason I show this is that we can use these types of ultra high resolution imaging data sets to inform the selection of our therapies. So let's look at an example of how this type of data is being used now to move toward targeted stimulation. This is work from Dr. Andrew Lee, a postdoctoral fellow in our lab, where what Dr. Lee did was he took freely available resting state fMRI data from the Human Connectome Project. This is 7 Tesla resting state fMRI data from 86 volunteers, and he superimposed a connectivity map on top of that 100 micron MRI scan. And the particular analysis that he did here was that he looked at default mode connectivity in the cortex and its subcortical connectivity within the thalamus, hypothalamus, basal forebrain, and brainstem. So as we scroll through this video now, we'll see in red, yellow, areas of positive correlations or positive connectivity with the default mode network nodes in the cortex. And in blue, we see areas of negative connectivity or anti-correlations with the cortex. And we see these positive correlations in the dorsal raphe, up through the pons and midbrain, and the ventral tegmental area. We see it in the lateral hypothalamus, as well as in the basal forebrain. We see positive correlations tracking up into the central thalamus here. And interestingly, we see these blue anti-correlations in the putamen. So let's take a closer look at that. Here's a zoomed view of a snapshot from that video. And let's place these findings within the mesocircuit hypothesis that Nico Schiff proposed in 2010, where the idea is that there is a GABAergic negative feedback loop from the striatum to the globus pallidus to the central thalamus to the frontoparietal cortex. And one of the appeals of this particular theory is that it appears to explain an otherwise paradoxical phenomenon where about 5% of patients with severe brain injuries and disorders of consciousness will awaken in response to a GABAergic medication like zolpidem or some of the benzodiazepines. And so the question is it possible that those patients have a disruption of one of these two GABAergic pathways, and the pharmacologic medication is restoring that GABAergic signaling, basically restoring a double negative, thereby disinhibiting the central thalamus and reactivating the frontoparietal cortex? That theory is very challenging to test in vivo. But does this new resting state fMRI techniques, here superimposed on the 100 micron MRI scan, give us a new opportunity to identify patients who might be responders to zolpidem or to benzodiazepines? It's important to point out here that these data are acquired at mesoscale on the order of 1 to 2 millimeter resolution, whereas the GABAergic signaling that we talked about in the mesocircuit is at microscale on the order of microns. And so it is not possible for these red and blue colors to give us microscopic data about the integrity of these circuits. But even with that limitation in mind, it's possible that these resting state fMRI data may provide a biomarker of the integrity of this mesocircuit. And here's the mesocircuit superimposed upon our connectivity map here. And one of the theories that we're going to be testing moving forward is whether we can use these types of ultra high resolution data to inform the selection of patients for these types of GABAergic therapies. To conclude, what is our responsibility to patients and their families? It has been remarkable to see the degree to which recent clinical guidelines, such as the 2018 guidelines supported by the American Academy of Neurology, the American Congress of Rehabilitation Medicine, and NIDALER, which is a US governmental organization, as well as the 2020 guidelines supported by the European Academy of Neurology, are now suggesting that some advanced imaging techniques have a role to play in the diagnostic and prognostic assessment of patients with disorders of consciousness. And it's been inspiring to see the degree to which experts in our field, people like Dr. Joe Finns, who's a neuroethicist, and whose book here, Rights Come to Mind, talks about access to these techniques as a civil right, akin to the Disability Rights Act passed by the United Nations in 2008. Now, again, as mentioned earlier, there are profound ethical questions for us to face here together as a community. And I certainly don't pretend to have the answer to all those questions as far as how we can ensure equitable access and how we can responsibly begin to implement these techniques clinically. But these are the types of questions that we are going to be faced with moving forward, in many cases by families who are aware of these techniques because they've been mentioned in the popular press or because they Google it and they find it on the internet. And so I look forward to the question and answer period, having a thoughtful discussion with all of you about how we can move forward with implementing these types of techniques in clinical care. And so with that, I'd like to thank you for your attention. If you'd like to learn more about our lab, here's our website, and I'm looking forward to the question and answer session.